Good evening, friends. It's a very, very, very sad day, and we've lost a very, very good soul. My one of my mentors, one of the guides, one of my philosophers in life, somebody who thousands of pulmonary students in this country, people who are working in pulmonary medicine, have learned a huge lot from Dr. Ashok Mahashur. Is no more. His sad demise has left a huge vacuum in our hearts, and that vacuum is difficult to fill. Dr. Mahashur started his journey from Nagpur, and within a period of a few years, he became one of the best teachers in pulmonary medicine, and literally thousands of students have been trained by him directly and indirectly. And his loss, his demise, is one of the saddest things that can happen. He had a very soft, at the same time a very warm personality, very friendly. Whenever a patient would go to him, he would keep singing his praises whenever we send a patient for second opinion to him. And at the same time, when it came to delivering talks, I remember his professorial talks, and he had a typical method of speaking, which was with a great emphasis and a very great clarity. And all his lectures, as he was one of the best professors that we had, were professorial. And with those words, I think we will observe a 15-second silence and then move on. Sir, we will miss you forever and always. So that brings me to today's topic. And our topic of discussion today is going to be molecular diagnosis of respiratory infections. And this is a unique theme. And for the first time, I would say, in our CCI history, we have two eminent microbiologists amongst us who will be delivering the talks, and then three of my colleague pulmonologists will join me in the panel discussion. So this is going to be the theme of it. And in today's time and days and times, we are often left with a situation where cultures will be coming, but they are not ready. And often the culture results are negative. And in these kind of difficult situations, you have to deal with infections. I would not say that a primary or maybe a borderline entry-level secondary setup would be able to do all the molecular diagnostics that these two microbiologists will talk about, but at the same time, at least for the tertiary care centers and big cities, it is realistic to go after the organisms in a methodical way, and molecular diagnostics are a great help when used in good time. So with that, let me introduce the first topic and the first speaker. The first speaker is my wife, Dr. Madhuwanti Abhyankar. She is the head of the Department of Microbiology and Molecular Diagnostics in AG Diagnostics Private Limited, Pune. She was a pioneer in setting up a TB PCR in the private setup, more or less one of the first ones in the country, definitely the first one in Pune in 1998. She established the TB culture by 2000 and eventually shifted on with 460 TB, eventually shifted to Versatrek and then eventually MGIT. She has been doing line probasis since 2014. She again was the first one to establish Gene Expert in the COVID times, and she has been doing the Gene Experts in TB scenarios since 2016. She is one of the most experienced microbiologists, medical microbiologists in this city, my city, which is Pune. She has been the lead assessor for NABL, microbiological and molecular diagnostics, since 2013. And she is going to talk today about the molecular diagnosis of respiratory infections with special emphasis on community-acquired and hospital-acquired infections and drug-resistant organisms.
Good evening, everybody. At the outset, let me thank CCI and their team for giving me this opportunity for sharing with you my experiences with regards to molecular diagnostics of respiratory infections with special reference to multi-drug resistance organisms. Let me share my screen. So if you look at the IDSA guidelines for community-acquired pneumonia, community-acquired pneumonia is essentially a radiological diagnosis. Sputum, gram smear, culture, blood cultures, etc. are not recommended for patients if the patients are with you in your OPD and you are just prescribing them antibiotics and they are going to be home isolated for the period of their illness and convalescence. Recommended only for recurring infections are all these procedures, for example, staining, cultures, etc. And for patients with history of hospital-acquired infections or history of hospital admission, IDSA recommends that some investigations are required at the outset from the laboratory, especially in the case of patients with a history of MRSA or Pseudomonas infections, because those are the worrying things in their area. IDSA does not mention ZN stain or Gene Expert Ultra. However, ICS and CCP guidelines do mention doing sputum AFB. However, I would sincerely recommend that if a pneumonia is of, say, more than 1 week duration, a Gene Expert Ultra would be a good test to add to your repertoire. Now, whatever test that you are going to do, be it a simple culture or be it a molecular test, specimen collection, according to me, is the most important aspect. Because if you don't collect a proper specimen, then the test result is going to be garbage. So in case of sputum, 3 to 5 ml of sample collected after deep coughing in a sterile screw-capped universal container, before brushing, before mouthwash, before mishri, in isolated room with negative pressure in order to not cause spread of infection to other people. This room should not be connected to central AC, and you should allow the aerosols to settle before opening the door. Induced sputum, bronchial lavage, bronchial aspirate, tracheal aspirate, transbronchial lung biopsies or needle aspirates will have different volume requirements. For example, in a BAL, I would need 10 ml. In a TBNA, I would be happy with whatever I got. This is a table from Dr. Apurva Shastri's microbiology textbook for lower respiratory tract infections. He divided into pneumonias, bronchitis, bronchiolitis. In pneumonia, community acquired and hospital acquired. So right now, viruses are at the top of our consideration. However, normally with people with no comorbidities or with comorbidities, bacteria would be our first organisms to look for. Also, if you see the identification tests that are recommended in the microbiology textbook, would be chiefly gram stain to look for whether the sample is good, contains a good amount of pusses, then do a culture from such good samples and follow the organisms which are isolated. Only in case of atypical or interstitial pneumonias are other tests recommended, like immunofluorescence tests or PCR tests and so on. So as you look at ventilator associated pneumonias, then yes, molecular tests will have a significant role, because you need rapid diagnosis and accurate diagnosis of the pathogenic organisms, and you are suspecting multiple pathogens perhaps in a ventilator associated pneumonia. So the molecular tests commonly available would be real-time PCRs, mostly multiplex, nucleic acid arrays, because they can diagnose hundreds or thousands of pathogens simultaneously, and mass spectroscopy, or what we call MALDI-TOF, then sequencing, and so on. So options are many. You can have pan-bacterial or pan-fungal PCRs. Pan-bacterial PCRs mainly based on 16S rRNA, pan-fungal PCRs also recently based on subunit RNAs, etc. They are mostly in-house assays, kits are not available, and doubtful would be the sensitivity depending on the sample which you are using and the significance of finding bacteria or fungi in a respiratory sample. Then other bacterial MDROs from the sample or from an isolate, you can do MRSA detection from even nasal swabs, from positive blood culture bottles, from culture isolates. Then you can detect vancomycin resistant enterococci from rectal swabs, from bacterial isolates. Also, Carba-R can be done on bacterial isolates mainly, but even from patient samples. So ICMR has given guidelines on different type of carbapenemase detecting assays, which can be as short as a couple of hours. They can be done on bacterial isolates largely. And various options are available like Carba-NP, MCIM test, etc. Molecular tests in these lines are the Expert Carba-R cartridge-based assay and the BioFire film array, mainly the BioFire pneumonia 2 panel. So these tests also differentiate in the different types of carbapenemase in addition to detection, whereas the Carba-NP and these assays will not specify which type of carbapenemase it is likely to be. And these are also CE-IVD approved assays, whereas some of the assays are research use only. So in the Expert Carba-R, you will get to know whether some specific type of carbapenemase is present, such as IMP, VIM, NDM, KPC, or OXA48, which are the important types of carbapenemase which are commonly seen. So if you look at the Ambler classification of carbapenemases, class A is KPC, IMA, class B is the metallo-beta-lactamases such as NDM, VIM, and IMP. Class C is your AMPCs, and class D is OXA, of which OXA48 is the important type. So you can see that these assays can detect all of the subtypes, although all carbapenemase cannot be detected by molecular assays. For that, you have to do phenotypic tests. Then coming to respiratory viruses, which are right now a topic of major discussions, such as the SARS-CoV-2, which is we are right now in the pandemic situation. Then the previous pandemic, which was influenza A, swine flu, then influenza B, then the respiratory syncytial virus. These viruses are commonly detected in our area. So you can have many options for detection of these viruses. You can have an individual PCR, Nowadays, many labs are having facilities for molecular testing, and this is very easily done if you have good facilities for extraction as well as PCR. Then you can have a multiplex RT-PCR. For example, same PCR can detect influenza A, H1, H3, influenza B, and RSV simultaneously. So this can be done on a RT-PCR open platform, or it can be done with a closed system such as GeneXpert. Then in GeneXpert, we have various varieties available, like for example, flu RSV, then subtype of influenza, that means A, B, H1N1, and so on. Then you can have an expert express assay for SARS-CoV-2 specifically, and you can have an expert express COVID, flu, RSV combined cartridge, which is just newly been introduced. So if you know what option you require, what is your requirement for this particular patient, you can go for any of these assays. So this is some of the data from our influenza testing, which we have done in the roughly past 2 months. So we totally got 334 samples for testing of influenza PCR, which we have a combined PCR, influenza A, H1, H3, influenza B, and RSV. So in that, we got around 197 negative samples, and the rest were positive. So in the positivity, the main culprit was H1N1. Around 100 samples of H1N1 were positive out of 334. And H3N2 was the next one, around 35. And 2 RSVs we detected in 2 adult or elderly patients who were probably grandparents to children who had got RSV. So instead of doing 1, 2, 3, 4 PCRs, you have an expert biofire film array. I talked about microarrays. This is a type of microarray. So it will help you detect multiple pathogens simultaneously. So which may be bacterial. This is a biofire pneumonia 2 panel, which will detect bacterial pathogens, atypical pathogens like Legionella, Mycoplasma, Chlamydia. And it will also detect viruses like influenza A, B, then even COVID is available, MERS is available on this same film array. In addition to detecting the organism, the film array can also detect resistance markers, like for example, in gram-negative bacilli, CTXM, KPC, NDM, OXA48, VIM, IMP, and in case of gram-positive organisms, markers of methicillin resistance such as MEC-A, MEC-C, and MREJ. So biofire respiratory panel is also available, so which detects mainly viral pathogens, so variety of them, and bacterial such as Bordetella, Chlamydia, and Mycoplasma. So respiratory panel is done on nasopharyngeal and oropharyngeal swabs, whereas for pneumonia panel, it is better to have a BAL or say at least sputum or tracheal aspirate. So how is the inclusivity of biofire panel? It covers around 70 to 90% of the causative agents in community-acquired pneumonia, shown by some studies, and around 80% in hospital-acquired pneumonia. And the resistance markers especially are also covered. So this is a case of a patient admitted with sudden acute respiratory insufficiency, negative for COVID, and had fever for 3 days, admitted to hospital for 3 days. Probably the cause would have been bacterial, viral, they didn't know. So they sent it for biofire pneumonia panel. And however, they sent it a nasopharyngeal and oropharyngeal swab. However, we were able to do it. Now, what we got was Acinetobacter around 10 to the power of 4 copies. Also, Serratia marcescens 10 to the power of 4 copies. And in the viral part, in the antibiotic resistance part, it was NDM was detected and VIM was detected. Then in the viruses section, influenza A was detected. So this was probably H1N1. In addition, these 2 bacteria which were detected, they were right now, probably colonizers, because the amount of admission was up 3 days. But certainly you have to look for subsequent infection by these same colonizers, self-same colonizers. If that happens, in that case, you already know their resistance markers. So thank you very much. This is my team at AG Diagnostics, and without whose cooperation, nothing is possible at AG Diagnostics. So thank you very much to my team.
Thank you, Dr. Madhuwanti, for that excellent talk. And it's my pleasure and privilege to introduce our second speaker for the day. And that is going to be Dr. Debkishore Gupta. He's an MD, PDF USA, FCMID from Netherlands, MBA in Hospital and Health Management Systems. He's working presently as Director, Medical Affairs in Cepheid, the Danaher Group. He is a consultant. Previously, he has worked as a consultant and head of the clinical microbiology and infectious diseases, head of the infection control, quality and clinical excellence, and has appeared as a faculty in DNB microbiology in various meetings. He has been previously associated with CK Birla Group of Hospitals and Ruby General Hospital. He is holding a postdoctoral fellowship in molecular microbiology from University of Central Florida, USA, fellowship in clinical microbiology and infectious diseases, FCMID from Netherlands, postgraduate diploma in infectious diseases, SSR, NABL, NABH, and WHO in patient safety, founder, secretary of HCWB chapter, organizing joint secretary of HISICON 2019, advisor to state government on dengue and COVID-19, member of faculty on CAHO, speaker in reputed national and international conference, more than 100 of them, multiple international collaborations, reviewer of international journal, number of publications, national 14, international 19. So with that, I'm sure we are convinced that we are going to talk to a real expert in this field. And his talk today is about tuberculosis, but we are not going to talk about the molecular diagnostics in drug-resistant tuberculosis. When we are saying that, we are assuming that most of us pulmonologists are well aware and well versed with the basic idea of a gene expert and a gene expert ultra and its importance in that part of the molecular diagnostics is not really alien to us, but the exciting things which are happening in the drug-resistant tuberculosis and the impact of molecular diagnostics in the drug-resistant tuberculosis will be his topic. With that, the podium is yours, Dr. Debkishore.
Greetings from Cepheid, and at the outset, I must thank the organizers for inviting me as a speaker for this conference. I'll share my screen now. We know TB still remains one of the world's deadliest infectious killers. Each day, more than 4,100 people lose life to this infectious disease, and more than 28,000 people fall ill because of this preventable and curable disease. So we need to do something extra to come to a diagnosis quicker and link more patients to care. Referring to this Global Tuberculosis Report 2021, we see that globally in 2020, 71% of people diagnosed with bacteriologically confirmed pulmonary TB were tested for rifampicin resistance, So this is definitely better than 61% in 2019 and 50% in 2018. But at the same time, you must acknowledge that this is not 100%. Among these, more than 132,000 cases of MDR or rifampicin-resistant TB and more than 25,000 cases of PXDR or XDR TB were detected, with a combined total of more than 150,000. And also the global coverage for testing of fluoroquinolone resistance is pretty dismal, just covering over 50% worldwide in 2020. So there is a need for accessible drug susceptibility test results for accurate diagnosis so that appropriate treatment can be started early and we can reduce the diagnostic delay and link more patients to care. We also know 1/3 of new TB cases go unnotified and undiagnosed. So again, referring to global report, India does not cut a very happy shed in this global incidence in TB rates in 2020. So the problem is selection of TB treatment regimens based only on detection of rifampicin resistance can result in suboptimal therapy for as high as 49% of patients with MDR or XDR TB compared to that with PDST. And also the line probe assay, high line probe assay, which is not suitable for near patient or point of care testing, as they require sophisticated laboratory testing, interpretation training, settings, and also it poses a huge biohazard risk to the users. We know India accounts for 27% of total global MDR TB cases. A lot of efforts got derailed because of COVID-19 pandemic. So DRTB remains one of the biggest hurdles in ending TB by 2025. I mean, the efforts got quite reversed because of COVID-19 pandemic, and 2020 is the only year in last one decade we see a lot of TB deaths, highest in last one decade. And there is also a limited scope on same-day test and treat approach for the DRTB population. So this still remains an aspiration, and monoresistance to INH is a growing concern, only 8% of it getting detected. Again, referring to this Lancet publication, which shows in India, the monoresistance is, or isoniazid rifampicin co-resistance is in the range of 5 to 10%. So knowing rifampicin resistance alone may not do the trick. Coming to the India burden for drug-resistant TB, the 2.7 million estimated incidence in India, almost 450,000 deaths happened due to TB in 2018 alone, and around 130,000 people notified with drug-resistant TB. Nearly 27% of total global drug-resistant TB burden lies in this country, and very interestingly, only 46,000 were started on second-line treatment. So there is a huge gap we can understand from this figure. As a result, India still remains the world capital of tuberculosis. Not only that, also for drug-resistant tuberculosis. So this is an Indian publication published in PLOS One. More than 1,600 patients were considered for this study, and samples reaching and completing the diagnostic algorithm at the reference laboratories. 13 reference laboratories were taken for this study, and the finding was quite depressing that number of rifampicin resistant TB patients completing the diagnostic algorithm was only 49%. So what's happening with this rest? We know this impact of COVID-19 pandemic has been huge for our country, and few countries like India, Indonesia, and Philippines really got affected as far as new diagnoses and notifications are concerned. There has been reduced access to TB diagnosis and treatment, which has resulted in increase in TB deaths, reductions in the number of people provided with treatment for drug-resistant TB, and also TB preventive treatment. And there is a fall in global spending on TB diagnostic, treatment, and prevention services. So this is perhaps the reason why WHO has chosen a theme for this year that invest in TB, save lives. So we need more funding for tuberculosis. So what's the need? We definitely need a rapid, fast diagnostic capabilities. We should be latest with having latest rapid tools, and also multiplexing capabilities to diagnose multiple drug resistances at once. So we cannot afford to have long trial and error phase where before deciding on the right anti-tubercular regimen. So we need to know the answers very quickly. same-day test and treat model to effectively manage DRTB patients. And also we need innovative solutions to be adopted at the national and also at the both public and private sector. So if you look into this lowermost quadrant of this slide, you will understand this is the management protocol for drug-resistant tuberculosis. This looks pretty complex. If I quote from WHO, we need to break the chain of DRTB and we need to simplify this patient pathway. Evolution of drug-resistant TB happens naturally, but also this is a consequence of ineffective treatment. At the individual level, when antibiotics are improperly selected or taken, and also at the programmatic level, where the use of standard regimens is best empirically, without including drug susceptibility testing. So this is a good publication from American Thoracic Society in 2019, where they have said that molecular DSTs should be obtained for rapid detection of mutations associated with resistance. When rifampicin resistance is detected, additional DST should be performed immediately for first-line drugs, fluoroquinolones, and aminoglycosides. And also resistance to fluoroquinolones should be excluded whenever isoniazid resistance is found. Now coming to the WHO recommendations and endorsements, in 2021, WHO has released a consolidated diagnostic guidelines and an operational handbook. So in the module 3 diagnosis part, rapid diagnostics for tuberculosis detection, the 2021 update, so WHO has very clearly recommended low complexity automated NATs for detection of resistance to isoniazid and second-line anti-TB agents. They have emphasized that initial detection of resistance to isoniazid and fluoroquinolones is rather than culture-based phenotypic DST, but also initial detection of resistance to ethionamide, which is better, more suitable than DNA sequencing, and also initial detection of resistance to amikacin rather than culture-based phenotypic DST. So under low complexity NAT, WHO has clearly mentioned expert NTB XDR, and they have also published data from 3 studies involving more than 1,000 participants where the high diagnostic accuracy of low complexity automated NATs was confirmed. You can see for isoniazid, fluoroquinolones, amikacin, and ethionamide, the sensitivities are pretty high in the range of 89 to 96%, and the specificity is as close to 99 and 100%. So WHO clearly endorses and says a single-step solution is now available using the first-in-class low-complexity automated NAT, which detects both INH and fluoroquinolone resistances simultaneously. This is a wonderful document also released by WHO, Operational Handbook on Tuberculosis. This speaks on policies and planning, equipment, digital data, quality assurance, recording and reporting, and also training and competency assessment. Now coming to the innovation from Cepheid, the GeneXpert 10-color technology. So this is the first PCR system with integrated 10-color capability for your hospital, your lab, and point-of-care settings. So what is this 10-color technology? So this is a combination of 6-color module plus calibration of 4 additional dyes. So this involves innovative excitation detection technique, and this is capable to detect an expanded number of genetic targets. This can be microbes, this can be antimicrobial resistance genes, disease loci, oncogenes, but it uses the same proven expert cartridge. So this is how it works. On the left-hand side, you'll see LEDs which get excited, and they are detected actually by photodetectors. There are some 6 photodetectors or fluorophores. So the technology is so unique and the dye chemistry is so intelligently innovated that more number of targets can be accommodated. So this is how this works, and special dye chemistries which has enabled the development of the first functional 10-color assay. So as a result, this has a power to independently monitor 10 or more signals, to detect an expanded number of genetic targets, to enable syndromic testing. You know, the syndromic testing is perhaps a true way forward. We need to obviate the trial and error phase and come to the diagnosis as early as possible to start the right treatment. This can scale up testing solutions available in any of our GeneXpert systems, and this can also deliver with the same exceptional speed, accuracy, and ease of use. So this shines a new light on TB diagnostics. So if you look into these cartridges, there has been a continued evolution in TB diagnostics. So in 2010, this 4-color to 6-color transition happened for Expert MTB RIF. Then in 2017, in Expert MTB RIF Ultra, this Melkup analysis concept was brought in. So this has given us more sensitivity in terms of resistance detection, for heteroresistance detection, and also for detecting silent mutations. And in 2020, there's a big transition from 6 color to 10 color in expert MTB XDR. Now, coming to the intended use of the expert MTB XDR, so what are the claimed samples? Unprocessed sputum samples, concentrated sediments prepared from sputum, and also BD mycobacterial growth indicator tube, that is midget culture. So isoniazid, ethionamide, fluoroquinolones, and second-line injectable drugs. The resistances associated mutations can be detected. And very importantly, this is a reflex test. So you don't have to wait for the resistance to be confirmed or identified. So any MTB detection or any MTB positive case can be reflex to this expert MTB XDR. So this is the intended use as a reflex test for a specimen that is determined to be MTB positive. So we also have onboard controls for each individual sample. We have sample volume adequacy. This ensures that you are having the right volume of sample. We also have probe check control. This ensures that the default factory settings are met. Also specimen processing control, SPC, which ensures that all the complex PCR steps have been quality assured. Results are available in less than 90 minutes. So this is a closed cartridge system which minimizes the risk of contamination, and on-demand results are available, and this is completely random access. Now coming to the drug resistance TB pathway in India, so this is how the current pathway looks like. It begins with smear microscopy or chest X-ray, lead time is 1 day, and then molecular TB test to confirm TB and rifampicin susceptibility. Again, it takes 1 day or same day report is available. Then based on the requirements, CDST and LPA, where the lead time is at least 2 months. So the frontline molecular test only confirms the first line drug resistance TB and only towards rifampicin. Treatment gets delayed by up to 2 to 3 months and maybe even more for most of the DRTB patients, and undiagnosed MDR-TB and XDR-TB patients poses a very high risk to the community. So not only the patient, individual patient is impacted, the patient spreads the infection in the community. So essentially the regimen is based on the local prevalence of disease and the experience of the treating physician. So this is largely empiric. Now this is where the innovation lies. When you reimagine DRTB diagnostics, the potential pathway looks like this. So you begin with expert MTB Ultra or expert MTB RIF. So it takes 80 minutes for detection for MTB, and irrespective of rifampicin susceptibility, you can reflex this to expert MTB XDR. It just takes 90 minutes to give the result. Then based on that, you can initiate or optimize treatment on the same day. So then you can put the sample for culture. This may take 4 to 6 weeks and even more than that. So you can always fine tune or adjust your treatment based on the culture results. But you have the option of starting the treatment on the same day based on this expert MTB XDR. So this supports universal DST program to route first-line drug resistance with isoniazid, test and treat on day 1, which has been an aspiration. Now this is being made feasible. Rapid molecular DST can be reported within 3 hours. This can reduce the gap between estimated and actual number of mono-ionage resistance and DRTB cases. So here lies the innovation and possibly the revolution, because you are essentially bringing down the time from more than 2 to 3 months to less than 90 minutes. So if you look into this cartridge, it's a 9-plex assay with 10 sloppy molecular beacons targeting 8 different Mycobacterium tuberculosis genes. And these are the targets, and these are the codon regions and nucleotide which are interrogated. So we have isoniazid, ethionamide, fluoroquinolones, and amikacin, kanamycin, capreomycin. So I'll quickly show you a clinical study where the clinical performance has been analyzed. So if you look into this, it has been analyzed against phenotypic DST and also versus sequencing. So the sensitivities are quite high in the range of 84 to 93%, and specificities are as high as 100%, except ethionamide is 64.7% because only one target has been there for ethionamide. But if you look into the sequencing part, even ethionamide looks good with sensitivity around 97.2%. But as far as specificities are concerned, this is close to 100%. Coming to the analytical performance, yes, for unprocessed sputum, the LOD is 136, and for sediment is 86. So analytical performance to detect MTB in the specimen is as expert MTB reef. And we also have sufficient concordance with existing TB tests. So MTB detection is comparable to expert MTB reef ultra. So certain operational specifications, yes, storage temperature is 2 to 28 degrees Celsius. And coming to this resistance detection, this is a very important slide. For isoniazid resistance, high and low, you have INHA promoter, you have CATG, FABG1, and OxyR AHPC intergenic region. For GER-A and GER-B, this can detect fluorocontrol resistance, high and low. You have 3 probes to target GER-A and 1 probe to target GER-B. And for SLIDs, you have RRS and EISP. RRS gives a pan resistance interpretation for SLIDs. And for EISP, you can have, if it is in the mutation in the 14, then this can be a cross resistance between amikacin and kanamycin. Otherwise, this gives an interpretation of kanamycin resistance. And as for ethionamide resistance, this is detected by INHA promoter. So coming to result interpretation, yes, it begins with INHA promoter. This gives an impression of MTB being detected or not. Then you have these certain analytes, and you have wild type and mutant windows or melting temperatures which are detected. So this is a snapshot how the different reports look like. So I'll quickly run through a few of the reports. So this is the window, MELCA window. You can see melt peaks. You have wild type window and mutant window. So if there is no resistance, everything is detected in the wild type window. And if there is resistance, this will be detected in the mutant window. As simple as that. So this is one report where MTB is detected, but no resistance, everything in the wild type window. And this is another case where MTB was detected, INH resistance detected, and low fluorocontrol resistance detected. Because CATG was detected, so this confers resistance to INH, and accordingly you can see quite a few resistances in the mutant window. And another example where you have INH resistance detected, low fluorocontrol detected, and kanamycin resistance detected because of EIS mutant B. So whereas amikacin and capreomycin resistance were not detected. So everything can be interpreted from the wild type and mutant window. And this is a very scary situation where everything in the mutant window, so all the resistance are picked up. Quickly, key publications. So this is published in Journal of Clinical Microbiology, the proof of concept application where the MELCA analysis to detect resistances were published. And this is first independent evaluation expert MTB XDR, where the limit of detection comparable to the expert MTB reef assay and successfully detected 16 clinically significant mutations in a challenge set. And this publication also speaks on a clinical study which was performed at 2 sites with 100 sputum and more than 200 clinical isolates. And this showed a sensitivity of in the range of 94 to 100% and specificity of 100% for all drugs except for ethionamide. So this is a very important slide from the last Union conference. It shows that expert XDR has no difference in performance compared to Heinprobe assay. In fact, this is sensitivity is somewhat better. An expert XDR assay includes INHA targets for FABG1 and HPC mutation, which are missed by first-line LPA. And non-determinate rates are very low, and user appraisal was very positive. So we have a publication to highlight the benefits or added value in terms of fast detection of extended drug resistance profiling, limited infrastructure requirements, and detection of all these resistances, fluorocontrol, isoniazid, ethionamides, and second-line injectables. So the key highlights, this has already demonstrated equivalent limit of detection to expert MTB reef, and 100% detection rate of tested resistance mutation, and showed some utility for resistance detection in strain mixtures. Very importantly, for the heteroresistance assessment, you know what is heteroresistance? There may be clinical failure if there is a resistant population in the overall tuberculosis, or there is a mixed population in the sputum. So there is 100% detection of resistance when resistant populations comprise as little as 10% of the mixture for INH resistance, 25% for fluorocontrol resistance, 50% for ethionamide, amikacin, and kanamycin resistance, and 60% for capreomycin resistance. So this expert MTB XDR assay can reliably detect a wide range of globally relevant isoniazid, ethionamide, fluorocontrol, and second-line injectable resistance mutations. And this can be a reliable, sensitive assay for tuberculosis, and expanded resistance detection can be a very, very useful tool for combating drug-resistant tuberculosis in this country. Thank you so much for your kind attention.
Thank you, Dr. Debkishore Gupta, for that brilliant talk. And you have enlightened us about the impact of molecular diagnostics in the present and the future context in the early diagnosis and effective management of drug-resistant tuberculosis. And I'm sure there are a lot of other questions which will crop up in our audience's mind. And to address that, we are going to deal with a panel which consists of Dr. Madhuwanti, then Dr. Debkishore Gupta, and it's my pleasure to invite the other three panel members right now for this discussion. Dr. Phillips Antony is joining us from Kannur, Kerala. He is working as a specialist pulmonologist in Sri Chand Specialty Hospital in Kannur, Kerala. And welcome, Dr. Phillips Antony. The second one is Dr. Archana B. She is an MBBS DNB DTCD, currently working as professor and head of the department for respiratory medicine in Rajeshwari Medical College and Hospital, Bengaluru. She has multiple publications in national and international journals, has presented papers in ARS 2000 and ATS 2015. She's been a principal investigator for national and international clinical trials. She is a peer reviewer of index journals, Clinical Respiratory Journal, Lung India, and Monaditi Archives of Chest Diseases, and Cancer Medicine. She is an investigator for National Bronchiectasis Registry. She is a subject expert for developing syllabus for CBMA-based curriculum of undergraduate clinical subject and RGUHS, that is Rajiv Gandhi University of Health Sciences. So with that, welcome Dr. Archana, and we are glad to have you on this panel. And last but not the least is going to be Dr. Karl Mehta. He is an MD in respiratory medicine. He's a consultant pulmonologist and sleep specialist. He is again from Bangalore. He's working with Vaidehi Super Specialty Hospital in Bangalore. And with that, I welcome the entire panel for an exciting discussion on the topics that have been touched by the speakers and all the doubts that the audience raises. Please send your questions while we are starting with our deliberations, and welcome all to this particular panel. Thank you. I think we have in today's web world, we have to be listening to the technical masters. And with that, I think let's begin the panel. Our apologies for not having Dr. Archana because there has been an emergency in her family. And because of that, it's impossible for her to join. But I'll fill in as one more student in front of these two stalwarts. One is my Supreme Court here, which is sitting next to me. So I have been learning all my life from her. And Debkishore, you have just listened to. So I think we have two excellent teachers, and possibly we are missing a lot of knowledge in these two, the technical territories that they belong to. So I think I'm going to first throw up I'll start the reverse way and start with Debkishore's talk, because that must be fresh in the panel's mind and as well as the audience's mind. So Dr. Antony and Dr. Karl, this is a question or a query for you. How excited are you about the XTB? I mean, gene expert
MTB XDR.
MTB XDR. How excited are you about it, and how soon do you foresee this being rolled out in our national program?
Very excited, sir. Very excited. The thing is, we have to wait for a significant amount of time for resistance direction as per our NTP program. Okay. Even though it is significantly a good thing right now for us, but time is the issue here. And XDR has significantly reduced it, and we are able to help our patients a lot faster.
Absolutely. Dr. Karl, anything on this?
Yeah, I just want to add that I was privileged to be a part of this session when they launched in Bangalore in February or March. So I had a chance to be on the panel there as well. Met Debkishore as well. So I was educated at that point in time, very excited. It has been rolled out to some extent in Bangalore. And as long as the sample is sent in a timely way, it's been very beneficial. And I also work at a trauma center, orthopedic and trauma center called Hosmat Hospital. So I've been trying to get, the neurosurgeons and the orthopedic infections like osteomyelitis or, any of their sepsis, orthopedic sepsis, and trying to teach them, how to send the samples so that, because these are the patients who also require it in a timely fashion before it spreads, before they lose their limb or their joint, or, they get whole body sepsis. So these are the kind of patients that also need to be targeted. So I think education from our side to our colleagues in other specialties is also, it's an uphill task, but it's something that we need to work towards. Yeah. So that's it.
Yeah, very, very well put. I think the time is the essence in so many of these situations. And I'll ask Madhuwanti one question about, because there has been, Debkishore has been talking about the LPA versus the TB-PCR or gene expert, and the gene expert, and the rapidity as well as the safety. So as a working microbiologist and the head of the microbiology unit in your laboratory, what is your experience in the terms of LPA? What is the turnaround time and how difficult it is to do it?
Well, the difference between the two is that with gene expert, you can use it for just one sample. So no need to have multiple samples, whereas for line probe assay, in order to have a good control and all that along with the samples, so you run in batches. And also it is a very technically skill is required for line probe assay. So that makes it a little bit labor intensive and cumbersome. So that's the difference as far as the lab goes.
So as far as I see, the rapidity with which you are able to diagnose a drug-resistant tuberculosis, of course, we'll look for bedaquiline resistant and whatnot. I mean, the time will come one day that we'll probably look for those another targets, and there is no end to that. But at the same time, I think what it can deliver to you is a convincing diagnosis of drug-resistant tuberculosis in a max 2 hours time. And I think the turnaround times is the big issue. In fact, even I work as a real life chest physician, and we do refer it to the government setups where then the patients are not affording, and the turnaround times with that LPA in the background seems to be ridiculous. In fact, some of my patients are on drug resistant regimens, even bedaquiline, and then have been taken off it because eventually it is found to be not drug resistant. So I think that kind of a crazy turnaround time will be really avoidable. I think avoidable is the best word I would put, because at this point in time we are doing LPA as our first backup kind of a thing. The moment the RIF resistance is detected, then the LPA is the first thing we start with, and simultaneously go ahead with the culture. So I think that's going to be the tricky scenario. And I think I have a question which to Dr. Debkishore also. What about gene expert rather than TB-PCR versus gene expert? So would it have some value somewhere? In which situations?
Yeah, I mean, great question actually. If you look into this WHO recommendations, definitely they're suggesting, low complexity nuts. So the problem with TB-PCR, because many of you are having wide experience in using TB-PCR before, the false positivity. So if you look into this gene expert, it's a nested PCR. That means there are two sets of primers. So the false positive element is grossly obviated because the next set joins with the true positives only. So this is how you can actually reduce the number of false positive hits, and you know it better how the false positive report can have an impact into patients' lives.
Yeah,
So
we had a project where about and bronchoscopic samples from TB suspects, and it was around 8 to 10% false positivities.
Yeah.
Clinically, we are not believing it to be tuberculosis at all, and it did not turn out to be tuberculosis. So I think that probably is the main thing. And Madhuwanti, is there a possible role for the TB-PCR in some other forms?
Yeah, it depends on the type of TB-PCR that you are doing. For example, like Dr. Debkishore said, that you should use multiple targets to avoid false positivity. Also, you can use it for detection of mycobacteria other than tuberculosis. At the present time, Gene Expert is lacking in that. They don't have a solution for MOT. Also, another thing which we could address is samples which are not done by Gene Expert, because Gene Expert at the moment is actually validated for respiratory samples like smear negative as well as smear positive, and extrapulmonary samples like CSF, but not much beyond that. So we have to actually validate them ourselves. So for TB-PCR, that is one opportunity.
Yeah, we have WHO recommendations, actually, endorsements for these off-label samples. But unfortunately, from Cepheid, we do not have this label claim because we are not part of those studies, so we cannot claim it.
That's right.
And NTM, that's a brilliant point, madam, because there's a need of the hour in our country especially. So we are working, and maybe in few years' time, we'll be launching the assay for MOT detection as well.
So Dr. Phillips and Dr. Karl, this is a question for you. So today, in this scenario, 2022, you have a precious sample, bronchoscopic sample from or whatever, it could be a sputum, no problem, from a TB suspect, and you are not really sure whether the person is coming from a very high prevalence drug resistance area or not. Would you be directly going for the XDR or would you wait and go the conventional way?
Sir, to be very honest with you, if the XDR is available to me, I would send the sample together for either Gene Expert MTB Ultra plus this XDR.
That's right.
And that's the best thing to do.
That's the best thing to do, correct. Yeah. I think Karl already has put his weight.
Yes, the challenge is always cost. I mean, if I'm able to do, if it's a private patient, I'm able to afford, they're able to afford, I will definitely do both tests. If I have to, like you said, go through the government channels, then we don't know what's going to be the outcome. I know they try to do their best, and they were doing very well actually prior to COVID, and then COVID really messed the whole system up. So I don't know what the future is going to be like. But generally for precious samples, I tend to push for both at the same time and try and spend more time with the patient to get that outcome. And then generally patients and the surgeons are very happy. And even for me, if it's a bronchoscopy, difficult bronchoscopy, it holds more credibility when we go through with it.
Yeah. There's a question from the audience chat box, and that is Kumud Mehta from Maharashtra, Mumbai. Are the genetic tests available to be used for treatment of the patient? That means, I suppose she means that if this is XDR documented, do you treat the patient? Is that what she means? I'm not too sure. Anybody can attempt this question. Debkishore, Madhuwanti.
So so for example, again, like a TB lymphadenopathy, which takes about 9 months, sometimes 12 months, difficult to treat cases, TB empyema. These patients, if you see an improvement through their CT scans on follow-up, generally you want to do if the nodes are still enlarged, you want to do a resampling. So in these cases, it makes sense to again repeat the markers and repeat. So it's these kind of cases you want to consider repeating it again.
Yeah, I think she's also referring to, possibly she's referring to the sequencing, because that is what she, genetic tests is possibly she's talking of sequencing. And I think, to my best knowledge, sequencing is now available in the commercial scene also in Mumbai, as well as many parts of the country. Yeah.
Like sequencing is available as pyrosequencing for detection of resistance markers for TB. So that can be one of the uses.
Yeah. So I think with that, I'm going to switch tracks and go back to Madhuwanti's talk. And that's going to be even the more real burning questions. And I'll start with what is relevant today. So both Dr. Karl, Dr. Antony, my question is, as clinicians, how often in today's COVID H1N1 co-pandemic scenario, because that is what I'm calling it, because today, if you really ask me, Madhuwanti showed us 100 positive for this, 100 H1N1s positive. We have had an ECMO death on H1N1. We have had so many H1N1s which are like mimicking the COVID scenario. And we know that COVID is the Omicron beta B2 or whatever that variant is no more that malignant in its behavior, plus the vaccination. So are we now testing PCR for COVID and H1N1 in the same go, or are we doing it separately? What is your clinical strategy? Dr. Karl, we can start with you. Again,
yes,
first person has to be recording. That is the bottom.
Yes, so that you're absolutely right. We actually had that wave July or through the first week of August. So for 3 weeks, we were having patients who were coming with respiratory tract infections, even patches on CT scan. Obviously, we were all alarm bells were with COVID. But fortunately, on discussion with few colleagues, we also realized that we'd forgotten about H1N1. So we started testing both simultaneously, and we got more H1N1s than we got COVID during that 3-week period. And obviously, we were in, at least my hospital, by the super specialty. I was able to alert the physicians, and we got good outcomes, because as long as we were able to detect it early, we were able to adapt to the interventions. We even had a few H1N1 with COVID co-infections, but
yes.
When we focused on both managing comorbidities, generally the outcomes have been very good. So we weren't having a problem. But that thing has to come in your mind. You have to remember, the thing is, we forgot for 2 years with COVID, we just completely forgot H1N1 because we weren't seeing those patients as often. So we need to keep these things in that you should know, based on your demographics, where, what are the times of year that you're going to suspect these kind of infections. So we need to heighten our awareness at that time.
That's right. Dr. Phillips?
Sir, I completely agree with Dr. Karl. First, it comes to clinical suspicion, whether it is a viral pneumonitis. And like you said, we are still with COVID in our heads. So we primarily send for RT-PCR or RAT COVID-19, and then we don't remember the H1N1. But right now, more than COVID-19, the prevalent virology is H1N1. So testing subsequently is mandated, and more important, it is the starting of antivirals as soon as possible, because delay will be problematic.
Yeah. I'm going to jump back to a little more to the bacterial infections. And the bacterial infections are another bear bug. And, hospitals are full of all the bugs I don't want, very frankly. I hate Acinetobacter, it is always there. I really hate drug-resistant Klebsiella, it's always there. And it looked like it had taken a big holiday with COVID. But the moment the second COVID wave came, all those bugs had come back. And then there is a lot of confusion. So I think the first basic question, just to the clinicians first, and then we will go back to the experts. One of them is, is it that we are doing a blood culture for every pneumonia as a mandatory scenario? Are we practicing it? It's supposed to be done, but are we doing it in real life? I'm not talking of the pneumonias which are managing in the OPD, but the ones which require a hospitalization, or those who are sick enough to get hospitalized. Anybody, any of you two?
Yeah, so I definitely do pan cultures in my patients with who are in sepsis and likely going in for multi-organ dysfunction. So generally they'll be diabetics with the borderline kidney disease or cardiac patients. So then I will be very aggressive. I will do pan cultures immediately. Many times we're able to catch the bugs early. We get a lot of patients with UTIs being the primary case, but it still helps because if early detect, it's all basically early detection, trying to catch them. If they've come and gotten admitted under us, they've already seen physicians, GPs, they've been already medicated with high generation cephalosporins also. So generally you need to intervene as soon as possible. So our protocol is quite strict that we want to get it done and sent. And then overall, if we detect it within that 48-hour window of their admission, their outcomes are a lot better. So that's the way we'll go about.
Yeah, Dr. Phillips, what's the scene in Kannur, Kerala?
Sir, in Kerala, generally we don't get the patients in that late stage of like suicides and sepsis, borderline MODS. So primarily it's the sputum cultures, but if indicated patient is in sepsis or is at risk of developing MODS, we definitely will go for a blood culture. But most often blood cultures don't turn positive. I think sputum cultures are always more sensitive.
Okay. Now I think I'm going to take you to the next level and ask you about both of you, and as well as I'll try and put in my opinion on this also about the panels and pneumonia panel. How often, in which patients? Respiratory panel, how often and in which patients? And of course, when even Madhuwanti said that it is not for everybody, it is for select patient population, but the value of it vis-a-vis, the cost. So I think how do you decide, and how relevant it is in today's scenario? Dr. Karl, you can start.
So my experience is a little limited. I've sent it now in a couple of cases with affordable patients, my bowel samples. I've also sent it in the critical care scenario, like I said, respiratory pneumonia in a patient with probably CKD or cardiac dysfunction. I'll send a nasal or ET swab for respiratory. But again, it's all about affordability. And I have to say, I haven't got very good results from the feedback. I don't know whether it is sampling error or, even the bowel, I've been getting no real results. Unless it's a really good sputum sample, it's been difficult for me to get anything. So my answer here is going to be very limited in this exposure. So if you can shed some light, I think it'll be more beneficial. Thank you, sir.
Yeah, I think our experience in this territory actually is related to the pandemic mainly, particularly in this, beyond second wave, end of the second wave, we started getting mucor, and then, drug resistant, various other bacteria have started coming back again. And then at that point in time, our pickup on various respiratory panels increased. And very frankly, even in the first wave, my own sample was done for biofire, what was that? Respiratory panel. RT-PCR. So that all came negative even for COVID, though I had a COVID pneumonia. So I think there are going to be false negatives at all times. I don't think that's not going to be the issue. Plus the idea that many people get loaded with antibiotics upfront, and therefore by the time the patient has reached us, he's already maybe 5, 6, 7 days on heavy duty antibiotics, and therefore again picking organisms becomes a bit of a problem. But if now in this scenario, today's scenario, we are picking it up in an increasing way. There are two fronts where we are picking it up. One is unsuspected viruses, like, of course, H1N1 is very routinely getting picked up in the biofires because we are not really covering it with anything whatsoever. And the other thing which we are picking up is the drug-resistant organisms. For example, Klebsiella, very relevant. The what and the NDMs and the those kind of beta-lactamases that are generated, and the the severe drug resistance that we are getting, that gets picked up increasingly. Acinetobacter gets documented in increasing number of patients. So I think this is where the pneumonia panel, no, that is what we will call it, pneumonia panels. I think pneumonia panels are relevant and useful, and I think it's a road, it's a work in progress. At this point in time, we are not right now in a process or position to recommend this as a standard of care. In fact, I would today dare say that the XDR TB cartridge is probably the best way to go forward immediately. Whereas I'm not able to say that about a BioFire because of the cost as well as the uncertainty that what kind of a value I will have. But a person with comorbidities, diabetic particularly is an important comorbidity, person who is exposed to infections in the past and antibiotics in the past, I would look for it. And in a person where I really don't know what the organism is, I think, and a person is very, very sick, I think even in that situation, I will look for it. Somebody who say typical is the H1N1 ARDS, which sets in hours. And it's a matter of time. Such a rapidly evolving scenario. If my RT-PCR is there, that's fine. If it is not there, I'll still look with a BioFire and second check it. So that is what my take on at this point in time on this. Dr. Debkishore,
can I make a point?
Please.
We have to consider the cost of the tests against the cost of maybe multiple antibiotics and multiple days in the ICU and so on and so forth. That is one point. Secondly, this is a vicious cycle. Like when the references for our tests are less, then the cost remains high because the people utilizing it remains low again. The number of labs doing the test also remains less. So the cost remains more and then the referral will remain less. So then the true use of the test doesn't become apparent till it becomes widely used.
I think this is a very excellent point from the logistics point of view, that yes, today, I don't think we bat an eyelid before writing an antibiotic worth 10,000 rupees. Yeah. And we are really thinking my patient is not affording the test because it is 17 or 18,000 rupees. But it's multiply that by 10 days or 7 days or whatever, the minimum that you are going to use it. I think it makes better sense to have the diagnosis upfront rather than not having it at all, because after 7 days of loading the antibiotic, in any case, the panels are going to come negative. Dr. Debkishore, your take on...
I'll just quote from the IDSA guideline on this antiviral testing, that, the several factors or variety of factors, definitely patient's severity of illness, duration of symptoms, comorbidities, and net state of immunosuppression, and availability of other ancillary tests, and also anticipated TAT, turnaround time, and the disease prevalence. So these are the factors which are typically quoted by IDSA, as also already described by everybody. And also coming to the cost effectiveness, I think if you look into the cost of solution, this is perhaps cost effective. And overall, if you look into this molecular panel testing, so definitely it reduces unnecessary antibiotic use, improve your antiviral prescribing, because we hardly talk about antiviral stewardship. We see a lot of antivirals are misused, just thinking that there may be some virus. And also limit additional ancillary testing, shorten hospital or emergency department length of stay, and definitely it optimizes the infection control practices. So keeping everything in mind, and all these factors are again very nicely mentioned in the latest IDSA guideline. So there is perhaps a very good role of this upfront molecular testing, and also sometimes for syndromic testing, but definitely a particular subset of patients should be kept on mind and based on clinical suspicion. No routine testing is generally supported.
I think very well said. Dr. Karl, you wanted to say something.
Yeah, I had a question for ma'am. Ma'am, can you shed some light on oronasal swab for biofiber versus BAL for biofiber? Do you see any difference in the sample quality in patients when the samples come to you?
Okay. First of all, one thing would be where you are expecting the virus to be, because nasopharyngeal and oropharyngeal swabs mainly are for virus isolation. So maybe in the first week, yes, they are a good option. But if your patient has been, say, sick for more than 8 to 10 days, then pneumonia panel makes more of a sense, because even the other bacterial infections added on would also be detected by the pneumonia panel.
And the issue of colonization of the upper airway by whatever is there is also there. So sometimes you just pick up a colonizer and the patient is clinically recovering, but you have a drug resistant colonizer, and that has to be separated from the other one. And I think a little mention about, because I think my ID consultants, I work in a tertiary care hospitals and I have 3 or 4 ID consultants, and they are very fond of Carbar, and they are also very fond of synergy testing. So I think, because when we are sort of at our wits' end, these are very valuable tests which decide which antibiotics, where are you going to use it, whether it is going to be that Zevicepta, Astronome combination, what are you going to combine with what. So I think it creates a much better perspective if you are able to, once again, the money spent on, say, for example, something like Carbar or something like your synergy test, it's not going to be as much as the amount that you're spending on very heavy high-end antibiotics, and that is also creating a further resistance in the entire hospital population. So I think that's also to be kept in mind. So we have to go into these territories increasingly. Though it is, of course, once again, you can't be doing that kind of a testing, say BioFire on an OPD walk-in patient. It's just not recommended, just not on. That will be just useless. But I think as you move towards more severe patients, hospitalized patients with comorbidities, and patients who are very likely to be previously used on heavy-duty antibiotics, I think one has to look for more and more aggressively and more rapidly worsening patients. So I think that's in a nutshell, that is going to be the message at this point in time, as I would say. Dr. Debkishore?
Yeah, I mean, definitely. This is a great tool for antibiotic stewardship, and with the mature hospitals like yours. So I think this is the right place to start this. And otherwise, life becomes rather simple with meropenem, teicoplanin, and colistin in everywhere you go in different hospitals of the country. And where we have really some good scientific scope to optimize antibiotics and deep dive once we know these genotypic resistance mechanisms well. So it's not completely dark. And definitely we can better optimize these antibiotics and also the upcoming antibiotics, this cefiderocol and others. So until we know these genotypics, this carbapenem resistance well, so we cannot, use it properly and save the antibiotics. A huge burden on colistin these days. I know certain hospitals where, very small scale hospitals where they use colistin because they believe that, well, this is the antibiotic. It never fails. So this upfront antibiotic is colistin. So these kind of situations are there. So this is high time that we should start understanding these genotypic resistance mechanisms well. We already have, because of COVID, a good landscape of molecular testing facility. We should start utilizing this because now COVID is going down, and this has given a very good maturity in terms of molecular testing. We can expand our install base of molecular testing. So I think a long way to go, and you should start and deep dive and start a higher level of better level of antibiotic stewardship, these genotypic resistance markers.
Yeah. So I think that sort of tells what the title we had given to this particular talk: Back to the Future, back into the genetics, into their genetic sequencing, where they came from, what is their lineage, and then future into the best of the antibiotics which are appropriate for that genetic information. So that is how it sums up in the terms of back to the future. So I would like to have concluding remarks from Dr. Phillips, Dr. Karl, then Dr. Debkishore and Madhuwanti, and then I'll conclude with my final comments. So we'll start with Phillips, sir.
Sir, two things. One, we have to look inwards, whether we are overusing or abusing carbapenems, because the extensive drug-resistant organism is on the rise. Are we doing our proper hospital infection control practices? and when to send the pneumonia biofire sampling. Secondly, we should start extensively using the Gene Expert XDR panel also, so that we can help our patients faster, reduce morbidities in a better way. We can take care of our patients whenever the patient is affordable. So we should be using the molecular testing panels as often and only when required.
Yes.
Karl?
So my takeaways would be that definitely, as everyone has pointed out, as this discussion has pointed out, the antibiotic and antiviral stewardship should be a priority. Using our clinical acumen, which we've developed over the years, is also very important. But it's also important to incorporate difficult patients, in discussions with your microbiology team, and come up with a strategy as to, if you're seeing a certain kind of patients, what are the strategies, so for better turnaround time, do they need more resources? So I think these are the kind of strategies that need to be adopted as well. Partnership between pulmonologists, physicians, and microbiology team for better infectious disease protocols within your hospital setting. And finally, I'd like to thank Nitin sir for conducting and moderating this session brilliantly. Thank you to our speakers, and thank you to my co-panelists. All the very best. Thank you.
Dr. Debkishore?
Yeah, I'll just begin by thanking Chess Council of India for organizing this wonderful program. So this is really, much appreciated, and I'm sure this will reach out to a lot of people, and this can motivate to practice.
It is 801 logins.
Wow, congratulations, sir.
Yeah.
And you moderated so well. So that's wonderful. So just to sum up, yes, this is the right time to, work on this antimicrobial stewardship in hand with infection prevention practices, and so that, precision medicine, which is a way forward, it should be practiced more and more. And we should do away with empiric therapy and all these kind of things. And finally, partnership, as Dr. Karl Mehta has rightly said, between right stakeholders. So this is absolutely essential, and these are the real way forward. Thank you so much.
Madhuwanti?
Yeah, so
I usually do not have the last word, but I'm reserving it for something else. So I'll tell you in the end.
today is your chance.
Today is the only chance I have of having the last word.
Okay, so while yes, molecular techniques are rapid and they are useful, and as everybody said, they can be used in the correct scenarios and not pan or for all the time. Also, not taking away anything from the phenotypic methods, such as simple culture, which can detect the suspicion of a carbapenemase, or ceftazidime avibactam aztreonam synergy test, which is actually not at all a molecular test. But these are useful in guiding your treatment choices. So not taking away from those either. So you have to look at the whole picture, the big picture. That is my message.
So thank you everybody for being with us. And I'm going to conclude not on the medical note, but on a poem, which is dedicated to dear Dr. Mahashur sir. And it is a short poem. It's an incomplete poem, but I think it will still do in this scenario. It's remembering him. That is what is important. So it's Marathi, but I think most of you will still pick up because there are enough some Sanskrit words in it. So, and most of us do understand that. So Guru asa संपूर्ण समर्पित, गुरु असा संपूर्ण समर्पित, आज सोडले हे जगत्याने, पण शिकवून हजारो शिष्य असे घडवले हे जगत्याने. गुरु असा संपूर्ण समर्पित, आज सोडले हे जगत्याने, पण शिकवून हजारो शिष्य असे घडवले हे जगत्याने. आठवणी राहतील साथ, शांत मृदू विनम्रती भाषा, अथक तयारी हरेक भाषण, मुद्दा मुद्दा ठासून बोलून. अव्याहत जगताचा गाडा कोणा वाचून कधी न थांबला. This world never stops for anybody, so life goes on. But अव्याहत जगताचा गाडा कोणा वाचून कधी न थांबला. पुन्हा महाशूर होणे नाही. पळभर ब्रह्माचा काठा इथे लांबला. पळभर काटा इथे लांबला. With that, Thank you very much for your attendance, patient listening, all your questions and your participation. Thank you, Dr. Debkishore. Thank you, Madhuwanti. Thank you, Karl. Thank you, Phillips. And we have missed Dr. Archana. Maybe some other time. So with that, I'll say goodbye and good evening to every one of you. Thank you. Thanks a lot for attending. Bye-bye.
Thank you.
Good night, sir. Thank you.
Thank you, sir.
Good night.